All right, so I'm going to talk to you a little bit about the evolution of HIV. I hope everybody here believes in evolution. Right, it's a constant struggle, isn't it? So this is my conflict of interest statement. I frequently say things that serve my interests. Actually, I think this is a greater hazard to the research enterprise than an occasional financial involvement that we have. And if you want to read more about it, there are a couple of papers written by my first wife listed on the bottom there, and you're welcome to read them. They're actually pretty good. Right. Okay. So just to summarize where we're going to go today, the therapies that have been developed in the past 25 years have really changed the landscape of this infection. But in both untreated infection and in treated infection, there's an important role for inflammation and immune activation. And I want you to walk away with this with the idea that in both of these settings, there's a soup. And the components of the soup we can measure and evaluate and link to morbid outcomes, but it's hard to know which of those things within the soup does what. And I think that's one of the challenges facing us in the next couple of years. This is a great paper. This is the first peer-reviewed report of AIDS, two actually, one on the West Coast by the Gottlieb Group and the other at NIH led by Henry Mazur. And this describes the occurrence of these unusual opportunistic infections in gay men. But what's really stunning about this work, and this table that you see comes from the first paper, is how rapidly these investigators recognized that there was something the matter with cell-mediated immunity, specifically a profound depletion in circulating CD4 T cells. But what people don't recognize or remember as well as they should, is that in this very same paper, the Gottlieb group identified immune activation as characteristic of this profound immune deficiency. So these T cells that were in circulation in these patients that were profoundly depleted for CD4 T cells were enriched for cells that expressed reactivity with OKT10, which we know the antigen recognized by OKT10 we now call CD8. In the early days, life was pretty horrible, and Len remembers this because he was one of the first docs here in town taking care of people with HIV infection. Even though the epidemic came to us a little later, our patients who showed up with HIV disease usually were coming here to die after having acquired infection somewhere out on the coast. But you can see that these instances of disease were really accelerating rapidly in the early and mid-'80s. And it was pretty horrible. It's real depressing. We didn't have any treatment that worked. The death rates were rising. We didn't really understand how this process, and in the early days until '83, we didn't really even have a pathogen. We didn't understand how this process caused immune deficiency, and the epidemic was moving from the coasts into the heartland where we were living. And to complicate all of this, many providers were very worried about the mechanisms of transmission and were concerned, of course, about whether they could acquire this infection from some level of contact with their patients. You all remember this young man. This is Ryan White, who was a young hemophiliac in Indiana, who was kept from going to school because people in his community were worried that he would infect his classmates. And after he died, the legislation, I don't remember whether the legislation was named after him before or after his death, but legislation was developed that have assured all of our patients access to care, which is kind of remarkable in the United States. It's one of the few kinds of sicknesses that one can have where you're pretty much guaranteed to get taken care of. I think it's a wonderful thing, but I think we could do better in other settings too. 1983, first demonstration of a virus that was implicated as etiologic and confirmed later by two other groups. the Gallo group at NIH and Jay Levy's group at UCSF. And this really changed everything because having the pathogen in hand allowed people to, one, identify persons who were infected, develop assays for the presence of infection, make sure that the blood supply itself was safe, and then start to dissect the mechanisms whereby this agent replicated and identify mechanisms to inhibit its replication. And that resulted in the first drug. And we tried all sorts of nonsense in the early years, all sorts of stuff. I remember we made transfer factor in our bathtub, and it did increase delayed type hypersensitivity in our patients, but not much beyond that. So this was the first agent, AZT, which was given to patients with advanced disease, and it did increase the survival. But you can see that the survival in this placebo-controlled trial was not durable. And the reason it wasn't durable is because the antiviral effects of the drug, of a single drug, were not durable. So on this graph, let me make sure I can make a light. This side better than that side? That side? I don't know. You want to vote? Yeah, that's right. I was sitting over there, and all the things were going, we're going to go to the left. And going to the left is good. Going to the left is good, politically. So here we have the rapid suppression of viral replication in plasma, viral levels in plasma, by administration of a single drug. But very rapidly, you could see that viral levels return, typically to a level maybe a little lower than baseline. These viruses, if you sequence them, typically will have a mutation that confers resistance to this drug. And sometimes, if that mutation confers diminished fitness, one would get levels, steady-state levels in plasma a bit lower, a little bit lower, usually not this much lower than one would see at baseline. So resistance really was the issue. And in the early days, the therapies were just horrendous. Not only did we have to treat with incompletely effective antiviral drugs, but because immune deficiency was persistent, we had to prophylax against opportunistic infections. So a typical patient would take a dozen or 2 dozen pills per day. Some of these were hard to tolerate. Some of these had to be given on a frequent schedule. AZT early on was given 5 times a day because we didn't really understand its intracellular pharmacodynamics. So yeah, it was a pretty rough time. And throughout this time, this is a picture of Janice Georgi, who sadly has died. But she championed the idea in the early 80s that immune activation was a critical driver of disease progression. And in a number of studies demonstrated, both her group and others, that the expression of CD38, again, that was the antigen reactive with OKT10, was a better predictor of disease progression than was viral load. And her stance was, people didn't buy it, but I think it turned out that she, in fact, was right. And there's a good example for this, reflecting the importance of immune activation when we look at non-human primates that can be infected with a precursor to HIV, simian immunodeficiency virus. And on the right here, we have a sooty mangabey, which is an African monkey who gets SIV infection. In fact, SIV-SM, SIV from sooty mangabeys, is the precursor of HIV-2, which is an HIV variant that is prevalent in West Africa. And when he gets infection, has high-level viremia, but despite the fact that he has high-level viremia, he almost never depletes his circulating CD4 T cells and almost never gets opportunistic infections. You can take that very same virus from him and infect an Asian monkey, and there's no SIV in Asia, so you can infect this Asian rhesus. And he too will develop high-level viremia, but just like us, he and his ancestors have never seen SIV or HIV as far as we know, develops circulating CD4 T cell depletion, develops opportunistic infections and death. And the difference between these, a key difference between these, is activation. Somehow this sooty mangabey, as well as other African non-human primate species who tolerate SIV infection without getting ill don't seem to get immune activation, whereas the rhesus, just like the humans who get HIV, the rhesus who is infected with SIV, not naturally, but experimentally, develops high-level immune activation. So there's a link here. Activation is associated with morbidity and tolerance, immunologic tolerance of some level. Tolerance of inflammation, tolerance of activation, failure to activate is associated with good prognosis. In the mid-90s, we stumbled, and stumbling is probably the wrong word, but came to the recognition that if you give enough antiviral agents together, and typically in those days it was 3 different drugs, one could get durable suppression of virus in plasma. And the reason that this is very good is several-fold. First, if you get durable suppression, the emergence of resistance, either from a pre-existent resistance mutation or from ongoing mutational evolution, was minimized by the fact that there's no viral replication or not very much viral replication. And in fact, one can durably suppress viral expression for years and years and years with a combination regimen that is profoundly suppressive. And this changed the world for us. With that, with the suppression of viral replication, one could see rapid increases in circulating CD4 T cell counts. And this was the first report of this by Brigitte Autran, showing that with initiation of combination antiviral therapy, there was a rapid rise in circulating CD4 T cell counts. And then, although it's not as apparent in this work, more so in some other studies, there is a second phase slower rise in circulating CD4 T cell counts. The first increase is likely a reflection of rapid release of lymphoid cells that had been trapped in inflammatory lymph nodes into the circulation. And the second CD4 rise is probably a consequence of homeostatic expansion of those cells as a consequence of normalization or relative normalization of homeostatic T cell responses. With this was a decrease in the occurrence of AIDS and AIDS-related mortalities. Seen here, this first decrease in these events was probably related to changes in definitions as well as improved prophylaxis, but this decrease in mortality that's quite striking is undoubtedly a consequence of better antiviral therapies. Now we have combination regimens where 3 drugs can be placed in a single pill taken once a day, and these agents are better tolerated, they have fewer toxicities, and obviously much easier to take than the left hand that contains an antiviral regimen. Those are just antiviral drugs in that left hand, all these guys here. For those of you on the right, a bunch of Republicans, they're over there. Okay. So what's the spectrum like now? What do things look like now? Well, it's different. We're not seeing many opportunistic infections now that we can suppress viral replication in the United States and other wealthy countries. What we're seeing is a spectrum of illness that looks a lot like the spectrum of illness we see in the general population, just occurring a little younger and a little more frequently. Cardiovascular disease, a spectrum of malignancies that are not the typical AIDS malignancies like non-Hodgkin's lymphoma and Kaposi sarcoma, but some occupation-related malignancies like lung cancers. We're seeing a lot of osteopenia. We're seeing lung disease, liver failure. Sometimes many of those liver failure events are related to ongoing co-infections with hepatitis viruses. We're seeing renal insufficiency, some cognitive decline that's a source of some debate and discussion, and certainly a lot of frailty. And what drives these events is probably not a single thing. Probably multiple factors play a role in the generation of these risks that include other comorbid conditions, other exposures such as cigarettes. Some may be related to the drugs that we use for the treatment of HIV disease, and some are undoubtedly related to inflammation that is the focus of my discussion. In recent times, the role of inflammation and coagulation as an important predictor of morbidity and mortality was derived from a large study called SMART. And the idea of this study, which was a collaborative study with which our group did not participate, was that there was thought that our drugs were responsible for a lot of the cardiovascular morbidities of HIV infection. And so this trial was designed to ask whether sustained antiviral therapy was as good as intermittent therapy. And the intermittent therapy group received antiviral therapy to decrease viral load, to increase CD4 T cell counts. When the counts got high enough, they'd stop the drug, and people would be off drugs. They'd be on a drug holiday for months and months and months until the CD4s dropped, and then they'd start again. And the rationale here was, one, you'd save some money, which would be important in the developing world, and two, if the drugs themselves were responsible for cardiovascular risk, you might save some cardiovascular risk. Well, the study was stopped early by the Data Safety Monitoring Board because the outcome was precisely the opposite of what was predicted by the study designers, which always goes back to what one of my colleagues and mentors always used to say: just do the damn experiment, because you never find out, what you find out is often much more interesting than what you predicted. So the study was stopped, and it turned out that intermittent therapy was associated with greater morbidity than sustained therapy, and greater morbidities included cardiovascular morbidities. And among the predictors of these cardiovascular morbidities were high levels of interleukin-6 that we just heard a great deal about. And I have a lot of questions for Stefan, and maybe he'll, in fact, I'm going to end my talk right now and ask him. No, later. High levels of D-dimers that are markers of ongoing coagulation and fibrinolysis as a consequence, and high levels of C-reactive protein that are generated by, can be generated by high exposure to interleukin-6, but in this readout, C-reactive protein levels were independent of the IL-6 levels. Maybe that's because the IL-6 levels are so variable over time and hard to measure. At least we think they're hard to measure. So we designed another study within the AIDS Clinical Trials Group. This was led by Alan Tenorio, which was to ask the question, among people who have complete virologic control, who are treated, and obviously the smart people, were bouncing up and down, some with virologic control, some without. We wanted to say, well, what if you just treat people with antiviral drugs, get complete control? What are the predictors of morbid outcomes? And so we took patients within the AIDS Clinical Trials Group cohort, who had samples stored away, and we identified 143 cases of non-accidental death, non-AIDS morbidity, heart attack, strokes, malignancy, and serious bacterial infections. And for each case, we identified 2 controls who were matched. Right. And we measured a whole bunch of inflammatory mediators in plasma, as well as markers of T-cell activation. And these forest plots show the odds ratio for the occurrence of bad events according to the highest versus the lowest levels of all the mediators on the left. So you can see that IL-6 levels were really very, very predictive. And this is before the event. And all these people had virologic control, were very predictive of these morbid events and very predictive of death, occurrence of malignancies, heart attacks, or strokes. And in fact, of all the things that we measured, IL-6 was the most robust predictor of morbid outcome. Now, the reason there are 2 bars here is the top bar is the unadjusted odds ratio, and the bottom bar represents an adjustment for CD4 T cell count. So independent. So in each of these, the bottom bar represents the ratio adjusted for CD4 T cell count. So what you can see is each of these factors: IL-6, IP-10, which is an interferon responsive chemokine, soluble TNF receptors 1 and 2, soluble CD14, which is an LPS receptor, and D-dimers. All these things were predictive, significantly predictive of morbid outcomes in these patients. And interestingly, the expression of HLA-DR and CD38 on CD8 T cells, which was a powerful predictor of disease progression in the natural history studies championed by the UCLA group, did not pan out at all to be predictive of morbid outcomes here. And in the same issue of JID, where my lab also did the inflammatory mediators, we've pretty much had the same findings suggested by in that work in a cohort with the disease, where the disease was a bit more advanced than in this one. But it gets even more interesting. These are the same relationships among these markers with morbid outcomes, the same odds ratios in these markers and morbid outcomes in the plasmas obtaken before antiviral therapy was started. So these are guys who have high-level ongoing viral replication, and we see exactly the same relationship. The only thing that falls out is IP10 that crosses the line and is no longer significant. So what this tells us is that in people with untreated infection, there is an inflammatory set point, a soup, that may be altered, and it is. These levels do fall largely with antiviral therapy over the course of a year. But there is an inflammatory soup, a set point, that determines the outcome irrespective of antiviral therapy. Here, the adjustment is not for CD4 T cell count, but adjusted for RNA levels. So independently of the magnitude of viral replication, these mediators, and again IL-6 being the most robust, predict morbid outcome, death, malignancy, stroke, or the entire spectrum. I just put this up to show you that one of the things that is a challenge for us, all these markers are related to each other. Each of these, when tested against the other at the same time point, is linked. There's a good correlation among some. For some, the correlations are tighter, but for every one of these correlations are significant. And so we've got this soup, and I think that complicates our lives mechanistically, because we don't know here yet, at least where I've gone so far, what's driving this heightened inflammation and coagulation. We don't know how these things cause disease, or at least I haven't said anything yet about that. And of all these things in the soup, we don't know which of these elements is on the causal pathway of disease and which is just a bystander. I want to say one other thing about this work, 329, and that is that the cases who developed these morbid outcomes had smaller CD4 gains than did the controls. And that CD4 effect, I showed you that the inflammatory mediators predicted outcome independent of CD4 T cell count, but CD4 T cell gain, the effect of CD4s, is also independent of these inflammatory mediators. So on the one hand, immune restoration is protective. On the other hand, high inflammation is linked to morbidity, and each of those independently have an impact on these outcomes. I want to say that because I think that's important. So I just want to, if we're concerned about immunologic failure, I want to show you a little data from a work that's done here in town called the Cleveland Immune Failure Project. This is something that Len and I sort of schemed on in a drunken stupor one evening, and at least I was drunk. I don't know if Len was, but it was an idea that we thought we'd look at the characterization. We characterized immunologic failure in our patients who were successfully treated, and the reason that this is important is, one, because CD4 failure, immunologic failure, is linked to morbid outcomes, and this has been shown in a number of studies, and about 20 to 30% of our patients who had been on antiviral therapies for a couple of years didn't bump their CD4 T cell counts to normal levels. So we called failure people who'd been on drugs for at least 2 years with completely undetectable virus and CD4 T cells less than 350, and the successes were CD4s over 500. And what's most important, the failures are in red, the successes are in blue, and healthy controls are in green, is the failures that had high-level cycling, significantly higher cycling, that's Ki67 positivity, when compared to the successes and controls. So somehow there's CD4 T cells. Remember, these are the cells that are not increasing. They're entering cell cycle. They're thinking about dividing. They seem to be doing it more so than the others, but they haven't succeeded at this. And this is important when we talk about mechanisms. And it's important also to recognize that the cycling was seen not in the naive cells, but in memory cells. And additionally, there's a linkage between immunologic failure and inflammation. Remember, our reds are the failures, our blues are the immune successes, and our healthy controls are the greens. Our failures have high levels of IL-6. They have high levels of D-dimer, telling us that there's ongoing coagulation and fibrinolysis. They tend to have higher levels of lipopolysaccharide, but these differences weren't quite significant. And they have high levels of soluble CD4 T, a monocyte marker, and a part of the LPS co-receptor story. So what's driving inflammation? Why are these guys inflamed? What are the and these are all the possibilities that people are thinking about now. What is it that's possibly driving residual inflammation, residual activation in patients on antiviral therapy with suppressed viremia? Well, one possibility, and entirely plausible, is that there's residual HIV production. We know now, and have known for a little while, that despite the fact that we can't measure much virus in blood, if you look carefully enough in tissues, you can find evidence of HIV expression. And if you pull off enough plasma from your patients, there are a couple of particles floating around. So these particles have to come from somewhere. So there is ongoing viral expression. Whether it's replication becomes another issue. Another possibility is that there are co-pathogens. We know, for example, that more than 90 to 95% of our patients are co-infected with cytomegalovirus, which is a very immunologically potent microbe and drives a very potent immune response. And he and perhaps some other fellows that often co-infect our patients may play a role in driving inflammation and activation. As you saw earlier, there is often an inflammatory environment within fat cells in visceral fat, and our patients often have a metabolic syndrome that's characterized by obesity and inflammatory fat, and this may be playing a role too in driving activation. And there's some reason to implicate some of our medications in some of this metabolic syndrome. There's evidence that a failure of regulatory responses may contribute to increased activation. And if we have individuals who have a cytopenia, a CD4 cytopenia, it's entirely plausible that some of the activation that we see is a consequence of a homeostatic response, a drive to increase cell numbers. All of these things can result in, plausibly result in a heightened inflammatory state. And I'm going to start by talking a little bit about microbial translocation, because I think that could be an important one too. So how does HIV infection and these inflammatory mediators drive the immune deficiency that we see? First thing that happens in HIV infection is the gut is wiped out of CD4 T cells. So the stain here is for CD4. This is a mucosal biopsy of an HIV negative gut, a biopsy of an HIV positive gut. Within the first 2 weeks of HIV infection, the lamina propria of the gut is wiped out of CD4 T cells. And the reason for this, and this is independent, irrespective as to the source of HIV access, whether it's acquired parenterally or vaginally or rectally, that those gut cells are wiped out. And that's because the gut mucosa is enriched for CD4 T cells that are both CD4 positive, memory and activated, and express CCR5, the other key co-receptor for the viral envelope that's necessary to cause infection. This wipeout is dramatic and catastrophic. And importantly, that gut lesion is rarely corrected with antiviral therapy. So even though you can suppress viral replication, we typically don't see a restoration of the CD4 T cell population within the gut lamina propria. The lymph nodes, too, are inflammatory, and we've looked at the lymph nodes of our patients and have identified multiple inflammatory mediators that are elevated in these nodes, and this particular one shows us the levels of interleukin-1 beta in the lymph nodes of HIV-negative patients, of HIV-positive viremic patients. Again, the brown stain is the IL-1 beta, and these are individuals who have had viral replication controlled by antiviral therapy. And these are summary data showing that in untreated infection, IL-1 beta levels are off the wall. They come down in treated infection, but still remain elevated when compared to levels in controls. Now, what's the consequence of this sustained inflammation in the lymph node? Well, the counter-regulatory response to inflammation in the node is expression of TGF-beta and the formation of fibrosis and collagen. And here you can see this blue stain demonstrating fibrous tissue in the lymph node. So the typical lymph node of a patient who's had HIV infection for a long time is fibrotic. That fibrosis blocks the normal cell trafficking that takes place in the lymph node. And of course, we have to think of the lymph node as one of the key immunologic organs where immune responses are generated. It blocks normal communication, so access to the IL-7 that is produced by stromal cells in the lymph node is limited. And so even though we may need IL-7 to generate T-cell expansion, the access of these cells to the IL-7 at the site where they are maturing and at the site where IL-7 is produced is often limited. But it gets worse because some of our cytokines, specifically IL-1, and to a lesser degree IL-6, can drive memory CD4 T cell proliferation. So they'll want these cells to proliferate. It'll push these cells into cycle. But lacking IL-7, they may not cycle properly. And it gets even worse than that because both IL-1 beta, IL-6, and interferon alpha will block T cell responses to IL-7. They down-modulate the IL-7 receptor alpha chain, CD127, and they block post-receptor ligation signaling. These cytokines do that result in diminished expression of the pro-survival molecule BCL2 and diminished expression of the integrin alpha-4 beta-7 that is necessary to allow T cells to repopulate the gut. And these data have been published by our group. Just want to show you a picture of the cycling that's driven by these cytokines. So here we've got CD4 cells in medium IL-6, IL-1 beta, and IL-7. And these images are images of cells that have been labeled with a fluorescence dye, a green fluorescent dye called CFSE. They're stimulated, they're allowed to divide, and each daughter cell will have half as much dye as the parent cell. So movement to the left, like here, is reflective of cell division. And you can see that IL-7 drives dramatic dilution of dye among naive, central memory, and effector memory cells. When we look at IL-1, for example, we get nothing in the naive population, but dramatic and profound expansion of memory, central memory, and effector memory cells, and a lesser response to IL-6. These data are also published in the Shive paper. Okay, so we have a setting where we've got an inflammatory node, a fibrotic node that just doesn't support homeostatic expansion the way it should. I'm going to change gears a little bit and talk about cardiovascular disease. So it's a story, and in this story, I'm going to say that the accumulation of inflammatory monocytes and CD8 T cells in the vascular endothelium plays a key role in the formation of atheromatous plaque. This is a PET CT scan of an HIV-positive patient on the right, an HIV-negative patient on the left, and you can see uptake of fluorodeoxyglucose on the right, especially in this axial view, patient versus control. So this means that there's a high level of metabolic activity in the wall of this vessel. That metabolic activity, I'm told by my cardiology colleagues, is typically mediated by infiltrating monocytes. We've been interested in monocytes for a long time, and we can characterize circulating monocytes by expression of CD14 and CD16. Traditional quiescent monocytes look like this, but from our HIV-positive patients on the right, we see a high number of what we call inflammatory monocytes and patrolling monocytes. Those numbers are increased in HIV infection. They elaborate inflammatory cytokines in response to a variety of elements, such as bacterial lipopolysaccharide and oxidized lipids. And they also express a receptor, CX3CR1, the Fractalkine receptor, that allows them to accumulate on the vascular endothelium. We know that monocytes have been linked to cardiovascular risk in that their soluble markers have been linked to cardiovascular disease in epidemiologic studies. Monocytes are also procoagulant. They can express on their cell surface a coagulation factor called tissue factor, which sits on the surface of the monocyte. And when it sees factor 7, cleaves it to activate it, that ultimately results in initiation of the extrinsic coagulation cascade that forms a clot. But before a clot forms, we get a character called thrombin. Don't forget thrombin. We'll get to him in a minute. When we look at the distribution of tissue factor on the surface of monocyte populations in HIV disease, the blue guys are patients with HIV disease who have controlled viremia. The black guys have uncontrolled viremia. We have these are controls. These guys over here are controls. These guys are controls. We see high-level tissue factor expression in HIV disease on inflammatory and patrolling monocytes. And the amazing thing here is that it's a phenotype superimposable on the phenotype of HIV uninfected people who are having an acute myocardial infarction. So these are guys with high procoagulant activity on their monocytes while they're having a heart attack. This is what it looks like. And that's sort of the way our patients walk around all the time. CD8 T cells. So I'm telling you a story that monocytes may participate in the cardiovascular risk in HIV infection. I'm now going to tell you why CD8 T cells may participate in this. First, in HIV disease, we have a persistent CD8 T cell expansion that persists even after antiviral drugs are initiated and viral suppression is complete. These cells are matured, they're senescent, but they're not HIV reactive. And it's not clear what's driving the CD8 T cell expansion, but in a number of clinical studies, high numbers of CD8 T cells predict morbid outcomes in treated infection. And these are the CD8 T cell counts in HIV positives and HIV negatives, and all these guys have virologic control. So you can see that on average, their circulating CD8 T cell numbers are about twice as high as those seen among HIV negative control, and they're linked to morbid outcomes. We also know that activated CD8s have been linked to atherosclerotic plaque in treated infection, and in untreated infection, in untreated persons, we can find activated CD8 T cells within the plaque itself. These CD8 T cells are enriched for expression of the same fractalkine receptor that's expressed by monocytes. So that means that they have a receptor that allows them to spend some time along the endothelium. These fractalkine receptor positive cells are also enriched for expression of the protease activated receptor type 1. And these are all people with treated HIV infection. These are the proportion of fractalkine receptor positive cells in HIV infection that are PAR1 positive. Why do we care about that? Because it turns out that PAR1 is cleaved and activated by thrombin. So here's the story. Here's a blood vessel. Here's the endothelium. Here's where we're forming an atherosclerotic plaque. We've got monocytes in HIV disease that are CX3CR1 positive, just tracking along the endothelium. We've got CD8 T cells that are CX3CR1 fractalkine receptor positive, just sort of trolling around the endothelium. HIV oxidized low-density lipoproteins, lipopolysaccharide, in work that I haven't shown you yet, but that we've published, can activate monocytes to express tissue factor that cleaves factor 7, results in initiation of a coagulation cascade that includes the formation of thrombin, that activates PAR1, that persuades these guys to move into this plaque. So that's the model. We think it's real. And in fact, some data that were generated by Shomo Panigrahi, who's here right now, tells us that in rhesus macaques, these are monkeys with SHIV infection. So this is, you're infected with a virus that looks like SIV and HIV, has the HIV envelope. First of all, we see inflammation in the SHIV-infected aortic endothelium. And this inflammation is characterized by CD8 cells, CD68 positive monocytes, and the overlay tells us that they're both pretty much in the same place. So we think this is actually going on. So just to summarize, inflammation and coagulation are both linked to immune deficiency and morbidity in HIV infection. Monocyte subsets are inflammatory and procoagulant, and this may be driven by microbial products, by inflammatory lipids, by HIV itself, as well as by immune regulatory homeostatic responses. Mature CD8 T cells are expanded, home to endovascular sites, and are linked to ART-era cardiovascular morbidities. And we think that coagulation and inflammation collaborate to drive increased cardiovascular risk in treated infection. And so we've got this inflammatory soup that I showed you about that predicts morbidity and mortality. But which of these elements in the soup are really on the causal pathway disease? Or do they all contribute? Or do they contribute differentially to different clinical outcomes, such that one of these inflammatory mediators drives immune deficiency, another is associated with an increased cardiovascular risk, another is associated with bone disease. If we really want to understand how these things happen, we really need to intervene in our patients, both systematically with broad inhibitors and selectively using targeted inhibitors, and build mechanistic monitoring into our treatment intervention trials. So these are the people who contributed to this work, both the folks in my laboratory, my faculty collaborators, and specifically Glenn, Grace, Benigno, Scott, Cliff, Chris David, and Richard Ransohoff, who's I guess not here anymore, and the NeWorks concept sheet 329 team that generated the inflammatory mediator studies that I've told you about. Thank you for your attention.